The Shift.
Well, tonight, mounting tensions as the men in cloth issue a 2-week ultimatum to the judiciary to expedite the reconstitution of IEBC.
And later on, we delve into the experiences you've had with SHA. What has been your story? Over to you, Regina Manyara.
Now, on November 22nd last year, the government took a bold step in healthcare reforms with the launch of the Social Health Insurance Act. This law introduced 3 key funds under the Social Health Authority: the Primary Healthcare Fund, the Social Health Insurance Fund, and the Emergency, Chronic and Critical Illness Fund. This initiative is part of the government's plan to ensure affordable healthcare for all and move us closer to universal health coverage. But how far have we come? Tonight, we speak to Principal Secretary, State Department for Medical Services, Harry Kimutai, for insights on what lies ahead. Our guest, as you can see there, is already here, and we want to hear from you. Send your questions and feedback, and we'll sample them during the interview. Now, the big question is, what has been your experience with the Social Health Authority so far? We'll delve into this important conversation after catching up on the day's stories with Mchuma and Tom. For now, our guest is in studio and was received by our very own Catherine Achenga, who is leading the production of The Shift.
The Shift.
Indeed, we shift gears and we focus on tonight's conversation, where an old adage states a healthy nation is a wealthy nation. Similarly, if you do not eat healthy, you will rely on medicine as your food, which in most cases is costly and can bankrupt your family. Perhaps in recognition of this, the government prioritized affordable health care. The goal was to shift the country's health story from curative care to preventive and promotive health. But for this to succeed, key issues like affordability, access, quality, and human resource must be addressed. This prompts the question, is the country's health sector healthy? Medical Services Principal Secretary Harry Kimutai is in studio to respond to this. I'm Regina Manyara, and this is A Shift. Now, let's start off with that particular question, Bona Pierce. Is the country's, in your opinion, is the country's health sector healthy? Is it a yes or no?
That I can say you, it is a yes.
It's a yes. And have you registered yourself for SHA?
Yes, I've registered myself. Number one, I think I was a contributor member of NHIF. And by virtue of being a contributor member of NHIF, I was shifted automatically to SHA. And my salary is known, so we deduct 2.75%, which has been remitted to SHA. So I am eligible for all the benefits under SHA.
Under SHA. So it's to say that you did not register you did not do the self-registration yourself. You were migrated, just as I was.
I did the self-registration.
All right.
Yes, I did both. I started with self-registration. You remember, we are the ones who were testing the system and to make sure that it's ready. And therefore, at that particular time, I registered. But when, again, it became automatic that I migrated, we just followed up with this, and again I reconfirmed that indeed I am a beneficiary of SHA.
Now, what was your experience, especially when you're doing your self-registration? Did you experience any challenges when registering?
The experience was very interesting. Number one, it was very simple because you simply need to dial *147#, and you will get a message which will confirm that these are your status, and you verify, check if that's your correct name using your ID, and there you are, you become already a registered member.
Now, do you believe that you have addressed the teething problems shifting to SHA?
Yes, we have addressed the teething problems, number one, because people are having challenges in registration. That has been resolved. Two, the hospitals initially did not understand the system. It took them a while to understand the system. But after that, when we took them through again and again through the training, they were able now to use the system without any challenges. So you remember yes, I can tell you that they were teething problems, but we resolved them within a short period.
Okay. Now let's shift. Or rather, let's flip the script here. We often hear about, how Kenyans are adjusting to shift, from NHIF now to SHA. But as PS Medical Services, how has it been, for you personally, overseeing this transition from NHIF to SHA on a personal level?
On a personal level, overseeing the transition from NHIF to SHA has been very interesting. In the first place, Kenyans were not used to a digital system. So when you told them that you need to register, and once you're registered, when you go to the facilities, you will have your details there already, and you will receive a treatment without any delay. They thought it was not going to be possible. But I think Kenyans, 6 days down the line, we are now steering a situation where we are able to access our healthcare system using the digital system. Two, we can now, in fact, as we continue improving the system, you do not need to have those cards. You use your ID card. So no more carrying of the cards other than your ID card.
So it's
just
electronic.
To confirm it is electronic, just to confirm your status.
Your personal experience, I can imagine the numerous calls. How was it? In brief.
In brief, my personal experience was one, calls that we received where people were saying, I'm not able to access treatment, specifically the ones who were on dialysis, because they had booked on that particular day, on the 1st of October, they had booked. But when they reached there, some of the facilities were not ready because they had not prepared, and they turned away the patients. That was the most difficult part for us to watch. Not because of the challenge of the system per se, but because they also just ignored our request that they need to continue treating the patients. If there is a system challenge, there was an alternative. We had given them alternatives for that, but they simply ignored. And what they did is they went and told the patients to pay cash where they had already paid their previous NHIF. And we had assured them that since you have automatically been migrated, you do not need to pay again.
Okay.
It was really painful at that particular time, but we blame the hospital administrators who did not heed our call at that particular time.
Okay. Now, let's have a listen to what the president had to say in his latest State of the Nation address there in regard to matters of universal health care.
Honorable members, universal health coverage is a cornerstone of our transformation agenda and a matter that touches every Kenyan family. Despite health being a devolved function, we acknowledge the immense financial burden that comes with health. Counties have struggled with shortages of medicine, equipment, sometimes staff, hindering service delivery and leaving countless Kenyans with suboptimal access to health care. It would have been easy for me to step back and leave this responsibility to counties alone. But that would have been a disservice to Kenyans and a betrayal to our Constitution. Instead of engaging in debates about healthcare being devolved, I have chosen the hardest but necessary path of addressing this challenge head on.
And on our big question tonight, we're asking you, what is your experience under SHA so far? That is a Social Health Authority. How's been your experience? Get us on X at KBC Channel 1. My X handle is at Ray Manyara. Now, the president addressed the issue of universal health care there. But then you have stated that the country's health sector is healthy.
Yes.
What makes you believe that?
Number one, the number of Kenyans who have registered under SHA, right now it's 15,800,000 as of today, and we expect this number continue increasing. That means they have confidence in the healthcare system. You've just heard the president say he had to take this thing head on. That means we had to make sure that we have reforms, and specifically the laws that were passed last year to strengthen and support delivery of UHC.
Okay. So what was fundamentally wrong with, the now defunct NHIF that government felt the need to change now to SHA? And now, just as we were getting used to SHA, we are talking about Taifa Care. Where do we draw the line?
Number one, NHIF had a lot of challenges. All right? Many hospitals, as we are speaking now, NHIF, the defunct NHIF owes those hospitals millions, in fact billions of Kenya shillings. That means that system was not working. They had stayed with the money or claims of the facilities for a longer period, some dating back 10 years. There was need to fix that. How do we come up with a system that will be able to fix that? We had to leverage on digitization. It's only through proper digitization, full digitization, that we're able to deliver UHC. One, we now have to know the facilities are actually registered. Two, we also want to know the doctors, the healthcare human resource providers, are they the right ones who are providing service? We need to know. So the issue of drugs, when you go to these facilities, you find that you do not get drugs. You go there, you see a doctor or a clinician, they prescribe, they cannot dispense at the public health facilities. And I'm talking about the public health facilities specifically, where a majority of Kenyans go. So we have to fix this, and we have to leverage on digitization.
Okay.
We also realized that there was need for us to pass other laws. For example, the Facility Improvement Fund, which will ring-fence the funds or the revenue that comes to that facility so that they are able to buy drugs. A patient goes there, must receive treatment and get the drugs or the medicine.
Now, this particular bill to ring fence these funds, where are we at in that?
All the counties have implemented the Facility Improvement Act, and therefore it allows the facility to retain more than 85% of their revenue. In fact, some counties have given 100%. That means no revenue will leave that facility to go and be used for any other activity within the county.
Now, some critics have come out and pointed that, it would have been far cheaper to upgrade NHIF to address those issues instead of a whole system overhaul. What's your take on that?
This NHIF system had been upgraded severally, many occasions. It reached a point where we realized it is not possible. One, the data that we got in the NHIF, for example, I'll give you an example. When we cross-checked the data that was in the NHIF with the National Registration Bureau, because they had their biometrics, that alone showed that there are about 3 million people who cannot be traced. So what does it tell you? That these 3 million could be what was the source of conduit in NHIF losing money.
Okay.
Because if you say you have a data of over 12 million, and when we verified against the single source of truth, which is the National Registration Bureau, where all our IDs and all our fingerprints are there, it gave us a return of only 9 million. So that means the system that we were keeping, the system that we are using, had challenges.
Okay.
And therefore, we had to overhaul the system.
Okay.
And we needed an integrated healthcare system, not just to deal with claims the way the NHIF was dealing with. We had to bring in a bigger system which digitizes what you call the health ecosystem. We needed to know whether this in terms of registration, and it links to the National Registration Bureau. If it comes to the issue of claims, it should process the claims automatically. It should not delay in processing the claims. there is less human intervention. We have tried to reduce the human intervention because we believe with a lot of processes requiring human intervention, it was a big challenge.
Okay, so going digital to curb fraud. Now, Kenyans are unclear about the differences or similarities between SHA, SHIF, and the recent mention of Taifa Care. Care to clarify?
Yes. When you talk of SHI, it means the Social Health Insurance, all right, which was created by an act of Parliament and assented to in 2023.
Yeah.
That is, they call it the SHI. And then SHA is a Social Health Authority. Social Health Authority was created by the SHI Act, the Social Health Insurance Act, which created an authority. And this authority is to manage 3 funds. Fund number 1 is primary health care funds. The second one is the Social Health Insurance Fund, now the SHIF. And then the third fund is Emergency, Chronic, and Critical Illness Fund.
Yeah. Mm-hmm.
So she is the one that created the act.
Yeah.
SHA is an authority. And then SHIF is the fund that you contribute to by paying 2.75% of your income.
Taifa Care?
Taifa Care now talks about the entire ecosystem and the benefits that you get under SHIF, where you benefit by your premium contribution, you get care. We have the primary health care fund, again, which is managed by the by SHA. And then you have the emergency, chronic, and critical illness fund. And therefore, the whole package is called Taifa Care, because you can benefit from all these funds that you're talking about.
Okay.
Therefore, it becomes a care for our nation.
Okay. So now, the healthcare tool is, or rather, the whole healthcare, as you're talking universal healthcare, is Taifa Care. But then we have the authority as SHA. Now, SHA is meant to address affordability, access, and quality healthcare. Then why are public servants demanding for enhanced cover, similar to one that they had on NHIF, if it's that awesome?
Now, it is, I want to tell you this, that the Social Health Insurance Act requires that all Kenyans contribute or pay their premiums at the rate of 2.75%. So that's for all Kenyans, irrespective of whether you are employed or not. Now, an employer gives benefits to the employee, among them the medical benefits. So the civil service, being an employer, provides a benefit, a medical benefit to their employees, what you used to call those days medical allowance that you pay to your employee. So they are entitled, and that's why they are asking for the enhanced system. Enhanced means it is no longer what they used to do with former NHIF. It is, the base is what you contribute under SHA. Those are your benefits which you are entitled to. And now, over and above, you are the SHIF benefits. Now your employer comes in to give you over and above, and therefore it caters for you as an employee of civil servant. So that's why an employee of civil servant says, I am still entitled to my medical cover, irrespective of my contribution. Yes.
But then someone would also argue, a critic of this, if you're supposed to be all equal, universal healthcare, that's the spirit of it, universal healthcare. Now we have public servants who are saying, yes, they're entitled to this, but then shouldn't it be then voluntary for those in the private sector who want to chip in more, to also have the enhanced care?
Let me tell you that even in the private sector, the companies also, just like the civil service, they also provide medical care to their staff over and above what the staff are contributing to SHA. So it is universal, it cuts across, but we are saying the ones that we pay under the social health insurance, it is for the entire nation. It is irrespective of your employment status, because we deduct 2.75% across the country. I mean, for those who are employed or unemployed. So it is.
So contributions by the public servants, are they going to be more, past the 2.75%?
No. It is 2.75% of their monthly salary.
So that doesn't change?
It doesn't
However,
change.
they get an enhanced cover?
No, it doesn't change.
Okay. So where the enhanced, how does it come in? Because they're owed by their employer?
The enhanced comes in because the employer provides a medical benefit.
All right.
And this time the employer is as a civil service. So that is the only difference.
Now, what are the concrete steps that are being taken to lower the cost of medicine? Because it accounts for 60% of, the cost of health services.
I can say that, number one, we are now trying to bring everybody to contribute. And therefore, we are saying we want to pull our resources together. Two, we also, you remember like those, when we started treating dialysis patients, especially in the country, the expense, the charges are very high. But when we spread this, we brought in a lot of dialysis machines. And now the cost came down to the last amount. Now, currently, we are charging 9,800 and something. So you can see when we have additional machines, we're able to spread, and therefore the demand and supply will work out. You realize that there's a lot of supply of these equipments, and therefore patients will have a choice where to go. That's number one. Number two, if we continue with this new system, we are also going to ask for quality care. And when you talk of quality care, we want to see that whatever you're providing is commensurate, the service you're providing is commensurate to the payments. So we are going to tighten that area, and we have told the KBC to really ensure that we strengthen the regulatory framework for enforcement so that patients are not overcharged in areas where they're supposed to pay less.
Well, that may be the case, Bwana PS. We do over 60-70% of our medicine is imported, yet it carries the hugest bulk, when it comes to health bills. So what are we doing about increasing production, local production of medicine?
As of now, you've seen we have opened up the special economic zones. Remember the president during the last year, during the celebration of Mashujaa Day, the Universal Healthcare Week, specifically that day, the president specifically approved a special economic zone in Thika to be specifically for pharmaceutical industries. That means the government is encouraging investments in the local production. We've also now made it mandatory by KEMSA to ring fence tenders for local companies. They will not be competing with the foreign companies, because we do know sometimes some of those countries provide subsidies to their manufacturers. So we've tried to ring fence. Any product that is manufactured locally will be given preference when it comes to government tenders.
To the tenders for manufacturing.
Yes.
Since you've mentioned KEMSA, before we take a quick breather, KEMSA is owed approximately 2 billion shillings by counties.
No, to be specific, it is 3.4.
3.4.
Yes.
Wow, that's understandable. So how are you ensuring that this does not happen again? Is there a mechanism to ensure that if government is giving these monies to the counties, or rather doing the disbursement, why not pay KEMSA direct? What are we thinking?
We looked at the constitution, we looked at the laws that we have currently. We had engagement with the National Treasury. It was not possible to deduct the money at source. And therefore, the money had to go first to the counties, and counties had other priorities. By the time they are paying KEMSA, it takes more than 90 days. Now, we are reforming this. We are saying, and we have engaged with the governors. We've agreed that they are ready now, because they have realized the importance of ensuring that their drugs are within their facilities. So with the proper digitization and now the social health working, we are going to pay directly to the facilities. And I've said earlier that we have an act now, which the counties have also enacted or adopted, they have now ring-fenced the revenue that goes to the facilities. Okay. So it will be the responsibility of each of the facilities to pay KEMSA, and they have accepted. Okay. We are doing that for the purpose of ensuring that we have drugs within the facilities, no delay in ordering, and again, the digital system that we have, the integrated health information system that we have, makes it easy because we are digitizing the public facilities as well, including digitizing the procurement system where, as they dispense the drugs, we'll be able to see the volume that they have currently. Does it require an order? When it reaches a certain level, it will trigger automatic order to KEMSA, and KEMSA will be able to supply. So it's going to be seamless. As I told you, there's no less human intervention because sometimes a delay in the paperwork, pushing for approvals. So this time it is digitized. It's going to be automatic in that case.
What are the timelines to have this actually rolled out?
To roll out this, we have within the program, as we procured the system and working with our suppliers, especially the consortium members, we have given ourselves a timeline of 2 years to fully digitize the entire ecosystem. But the speed at which we are going, I can tell you, we might not. We are going to achieve this in a record time of less than 1 year or 1 year.
Okay. And on that note, with speed, we take a quick breather. What we're looking at focusing on affordability, access, and quality healthcare. We'll be right back.
Mamlaka ya ukusanyaji ushuru nchini inakuletea kampeni ya umma ya G-Nice na Risiti Legit. Thibitisha risiti yako ukitumia app ya Risiti Legit, upate nafasi ya kuibuka mshindi wa zawadi kemkem kama vile shilingi milioni 1 pesa taslim, laptops, televisheni ya inchi 50, smartphones na zawadi zingine. Disemba tarehe 4, siku ya Jumatano, kutana na msafara wetu Homa Bay katika maeneo ya Oyugis, Rangwe, Rodi, Mthiwa, Sori, Kendu Bay, Homa Bay Town na Mbita. Alhamisi tarehe 5 Disemba tutakuwa Kisii, maeneo ya Kisii Town, Ogembo, Suneka, Kanyenya, Nyamache, Marani, Masimba na Keumbu. Pata app ya Risiti Legit kwa Google Play Store au App Store kwa maelezo ya kuingia katika mashindano ya Risiti Legit. G-Nice na Risiti Legit. KRA, tulipe ushuru tujitegemee.
Say bye-bye to FOMO, the fear of missing out, by downloading the KBC Online app that gives you access to everything you love. Get the latest news, sport,
it's a class.
music, entertainment news, live radio, and so much more at the palm of your hands. To get the app, simply search KBC Mobile Digital App in your Google Play or App Store and download the app. Catch what you want, anytime, anywhere. Stay connected. Stay ahead with KBC Mobile Digital App.
Welcome back. This is TheShift. Now, P.S. Kimutai, my grandma back in Kibirisha, Meru County, really struggles using the cell phone. How are you ensuring that now that we've termed it Taifa Care, she's not left out from the benefits, especially when it comes to the registration process?
Thank you. I think you remember last year we also commissioned, the President commissioned 100,000 community health promoters. In fact, the figure has gone up now to about 107,000. Now, we have trained these community health promoters because we also issued them with smartphones. So they are, as they visit the households, which they are supposed to supervise in terms of their health care, they will be doing registration. And once they've registered those households, then the household will benefit automatically from the social health insurance. Registration alone gives you benefits at level 2 and level 3 without paying even your premiums. Level 4, 5, and 6 is when your social health insurance contributions will come in. So that means it's accessible. It is available for all Kenyans, irrespective of your status.
So I can just walk in with my documents, whether I'm registered, and get service at level 2, 3, 4?
Level 2, 3.
Level 2, 3.
Yes, and we have also opened now level 4 for PHC, just because we realize that the challenge of accessibility is there. Some people live within the level 4 facility, so we cannot take them back to go and start in level 3. Yeah. So we opened up, we realized there was that challenge, and we opened up for them.
So how many hospitals have registered level 4 actually have enrolled on SHA? Because there's an appeal from government to have level 4, medical facilities also on board on SHA. Where are we at with that?
Yes, we have all public facilities, all of them, about 5,000 have been registered for the PHC, and now level 4 and 5. Because mostly the counties are the ones who they go up to level 5. Level 6 are for the national referral hospitals, and these are the Kenyatta National Hospital, for example, KUTRH, Madare, and MTRH, that is Moi Teaching and Referral Hospital. Those are level 6.
So CHPs are supposed to assist members of the public, register on this particular platform.
Yes.
And we've seen a report that this is a challenge, not just among those who are struggling with tech, but we also are having a problem registering on the portal. How are you addressing this?
What we've did is, with our service providers, we have given, we whitewashed the CHP's phones to allow them use their phones without needing bundles. So that means they have enough access to data for them to continue registering. So that's not a challenge anymore. And then for those who need to go to the portal, definitely they have to go to a website where we have internet, and they're able to access that.
Okay.
So that is possible. Those who have smartphones, they will be able to also use that, because with the bundles, they'll be able to access the portal.
Now, there's a case in point where a person used to seek medical services at a level 4 hospital under the now defunct NHIF, but now they're not allowed, or they cannot access services at the level 4 facility. They're being referred to level 1 for them to get referred.
Okay, let me explain to you. Level 1 is the community unit. That means the CHP when they visit the household. So we refer that to level 1 because it is being supported by the CHP. And they go there, they do basic. They take your pressure, they take your glucose level, and they talk to you. And then they quickly tell you to visit the next facility if you have a problem. Say, for example, if your pressure is high, they will take you to the next facility. That is level 2. Now, level 2 is the dispensary, all right?
Yes.
And then in level 2, there are certain basic services that will be offered at that level. And that's level 2 and level 3, which is the health center. Now, level 4, we had decided level 4 to start using the SHIFT, or the social health insurance fund. That means your contribution now, where we wanted to use level 2 and level 3 because it is free. Now, if you go to level 4, we had designed the system in a way that at level 4, that's when you start using your social health insurance fund, which you contribute. But you see, Kenyans are saying, if I can access services at my nearest hospital is
level 4, why shouldn't I just walk in?
Why should I go this?
Yes.
But you see, we also wanted you to benefit simple ailments. Sometimes that you find somebody has gone to a level 4, level 5, level 6. You go to our level 6, you realize that there are people who are just having simple ailments who needs to be checked. Say, for example, to be stated whether they have malaria or not, and then they go back home. So why should you use your shift contributions? So, but now they're saying, okay, open for us, we want to access level 4. So we are now saying we have opened level 4 because level 4 will be entitled to capitation. So we wanted capitation to be done at level 2 and level 3, and not level 4. So we are trying to reorganize our referral system. So for now, because it's a new system, we are now taking Kenyans through, and we are telling them, you are entitled to free medical cover at level 2 and 3. When you go to level 4, that means that you either need a specialized care or go for specialized tests that are taken at that level 4, where now your card starts being used.
So for this case study, they can now freely walk to level 4 because they were already getting the services from level 4 before we did the transition.
Yes.
Can they access and use their capitation funds? Since we've been, I think...
Right now what we did, because of the outcry, we opened that.
Okay.
We gave a policy directive that we now go up to level 4. Yeah. But you see, we were discussing with the governors, and they're saying they realized that they were providing at level 4 and even their level 5, they were providing services which are normally supposed to be provided at level 2 and 3. And that's why you go to their health centers and dispensaries, you find there are no people, there are no patients who go there because they're used to going to level 4. And you go to level 4, you'll find it is very much crowded.
Okay.
Now we want to have a referral system. It will take a while for us to understand, and a new system, it will be okay.
Okay, we'll be keeping tabs on that. Now, you have stated that no patient should be denied care due to unpaid contributions, provided they are registered with SHA. Yet, reports suggest that Kenyans are being turned away. What's your comment on this?
You see, I said that Kenyans should access free care at level 2 and level 3 once they are registered. Okay? But if when you go to level 4, 5, 6, and you're not a paid up member, it's like you've gone to that facility where you're supposed to pay and you don't have money. Okay. You are supposed to register and pay your premiums for you to access service at level 4, level 5, and 6. And then these services, it depends with the kind of disease that you have, so which cannot be treated at level 2 and 3. Because that's when we say it's been referred. These are cases of referral. So when you go there now is when you use your social health insurance contributions.
Thank you for that clarity. I think it was not clear in the communication that free care is only on level 2 and 3. Now, what is the current state of the government's medical leasing program, medical equipment leasing program?
The medical leasing program, yes, the MES,
yes,
program lapsed last year. Now we've come up with a new program. It's called the National Equipment Support to Counties. Now this is a different model which we learned from the MES, the Medical Equipment Program. How does it operate? One, we floated an open tender together with the county governments, and we invited the bidders to come on board to say, we want bidders who are able to provide what's called fee for service. Meaning, you bring your machine, install in the facility, you provide service, and you charge that facility. For example, you bring in a dialysis machine, it is placed in a facility, the vendor, the supplier will be paying the consumables, will be servicing, and the role of the county is just to provide a facility or a room where they install it, and then patients will go there, they will be treated using their shift, they will be charged, they will claim that from the social health authority. When they pay back the facility claims, then they will pay the owner of the machine the service that they have rendered. So the counties will not incur any cost of maintenance. That's the beauty of it, because you realize that you go to a county, you have an equipment, sometimes it's not working, procurement has not been done for consumables. So we realize that for us to achieve universal health care, we need the private sector to come in and support. That's one area of private sector collaboration with the county government or the facility owners.
Okay.
So it is one that it's ready now.
It's ready?
We are getting now, the counties are giving us the list of the equipments that they need, which will be given to these suppliers. They will now go and install within the facilities that have been identified. If it's a dialysis, if it is X-ray machine, MRI, CT scan, now this is going to be possible without investment. Previously, it was really a big challenge to the counties because they didn't have the budget.
And also those who are supplying did not get their monies paid. I hope that is going to be corrected under the new program there. Now, Kenya moves towards a middle income status and donor funding is decreasing. What is your plan, in ensuring continued access to free ARVs, malaria drugs, as well as TB drugs?
You see, we have changed the funding model. The funding model is based on our contributions under Social Health Authority now. Yeah. So we are now going to bring everybody on board. So as the development partners, donors are pulling away because of our status, economic status, and they have given us notice. Most of them have given us notice until 2030. That within that 2030, you should have budgeted for what they have been supporting us with. Okay. And we are coming up with a sustainability roadmap. For example, we now have the HIV/AIDS sustainability program we launched on FAST, where we are now seeing how and then do we phase out the development partners. Okay. So we want to integrate this into our system. We know everybody's contributing, irrespective of your status. If you are poor, indigent, then the government will take care of you. Okay. So you should then be entitled. We are going to include those ARV drugs into our social health insurance benefits.
So currently, is HIV/AIDS management covered under SHA?
Currently, no. Because it is being funded by the government and the development partners. So we could not again put that as a package. So they are still accessing the ARV drugs, which is being funded by the national government through the GOK and the development partners like Global Fund, PEPFAR, and others. Vaccines, similar to vaccines, so we are having the same. So in future now, for example, vaccines will be under the benefit packages that one is entitled.
Now, there seems to be a lot of data collection, to onboard on SHA. Yes. How safe is that data?
This data is safe because we did the data impact assessment that was done by the Office of the Data Protection, and we are compliant with the data protection laws. So the data is safe, and Kenyans should be assured of that.
That is good because they talk data is king. So does the government have the capacity to evaluate, the quality of services, in public health facilities, given the limited resources, both human capital as well as medicine and equipment?
We have various regulatory bodies that are supposed to do that. But you realize that the enforcement is weak. Now, what we are doing is we realize with so many government agencies playing into the space of regulatory, we have the Kenya Medical Doctors and Dentist Practitioners Council, we have the Kenya Clinical Officers Council. So they are supposed to help us in regulating services delivered by the professionals at the same time by the facility owners. There's been a loophole there. Okay. What we are doing now is we're coming up with a new bill, what's called the Quality of Care Bill. This Quality of Care Bill will spell out clearly what a facility needs to have for it to be registered, all right? What caliber of the doctors that they employ there, all right? So we are looking at the care in totality. the care in totality. So from facilities, equipment that they have, and the kind of doctors they have, all right? So that are they specialized doctors? If you say you're providing this service, do you have these doctors? So we realize that some of them just talk of this kind of service being offered here, but they don't have the specialized doctors. You'll find again the general physicians are the ones who are doing that.
Now you have led me to this question. A majority of doctors employed in public facilities also run private hospitals. Case in point, you go for consultation or treatment in a government facility, but you're referred for treatment in a private facility. How are you addressing this conflict of interest?
We are addressing that through digitization.
Okay.
Number one, if you're an employee of a government, all right, you are supposed to be on duty from 8 to 5. Now, when you walk in there, you log in because we are going to supply them with the gadgets. They need to log in. They will provide, because our system of delivery of healthcare is going to, there's no more paperwork. Once we've given them all the gadgets. So they log in and then they provide service. That means within that week, if they are on duty, they will not be able to provide, go to their clinics. And we are saying this because the system will be able to detect them because they have their record, their number, which is now, we have what's called the human resource or the registry, which is within the integrated healthcare system. And if the doctor goes to another facility, should be able to log in from that facility. Okay. And if you're a government doctor employed by the government and you are supposed to be on duty, we get that you've logged in here and you've moved and you went in and logged in there. Were you off duty? All right? So the system is able to read and understand that this one ought to have been here because you are licensed to operate from here. And if you find that you are again in another facility, and unless you're off duty, so that claim will not be honored by SHA because you are providing service at the wrong place.
Biometrics to curb inefficiencies and fraud.
Yes.
We're still speaking about matters of health, focusing on the transition where we find ourselves, that is under the Social Health Authority. We'll take a quick breather. When we come back, we're going to be looking at public sentiments. That includes your feedback, as well as the quality of services that are being offered in our health facilities. We'll be right back.
The Shift.
Star 570 hash. Option 1 kuna PS5 na ni full package na inakuja na JBL Party Box. Your boom experience pia iko.
Do I look like those losers who watch movies on the laptop?
Now I have confirmed you are like a lazy person.
Even the richest person in the world, like Zoga Baga, Bill Gates, they don't have enough money. They are very, very busy looking for more and more money.
Yes, I enjoy.
You want some more?
Yes.
No, Kamene. It's not much. Take that.
Guys, I am now an executive. I am taking tea from the land bottle.
Keep my dad's name out of your dirty mouth. And by the way, my dad is not rich. He is wealthy. Muskia.
The Shift.
Indeed, the shift. So what has been your experience under the SHA so far? Let's look at what you had to say on our poll. Let's have it up there on graphics to see what Kenyans have had to say in regard with to their experiences. Do you think the government has resolved the shift teething problems? Well, we have yes at 40, but no at around 262. Bonapius, what do you have to say about that? You've told us that the system is working, but Kenyans from that particular poll that is very much live, a majority do not seem to agree with your sentiments.
I don't know. If they don't agree, they needed to tell us exactly what service areas that they are not getting service.
Okay.
But what we know is, if you are registered and you go to level 2, level 3, you should get service.
You should get service.
If you have paid up member, registered and paid up member, if you go to level 4, 5, you should get service.
Okay.
Because it is your premiums that will be used. We have now many Kenyans.
Now, these are the areas, or the concerns, areas of concerns. We're going to be playing them there. Now, medics have raised concerns about, long working hours due to understaffing, which has then in turn increased the risk of medical errors. How are you addressing that issue?
I think the medics have said that they're working long hours. I remember that was one of the sticky issues during their strike, and we had engaged them. Okay. We told them, for example, the interns. We've told them that the interns should work within the hours that they're supposed to work. Nobody should work an extra minute, not even an hour, an extra minute. So we are saying, let the doctors work within the hours that they're supposed to work. Mm-hmm. If that facility faces a challenge, or that hospital faces a challenge, then that means there is need for employment of additional doctor. Mm-hmm. So for me, we need to be honest to ourselves, so that the facility owners or the government, if it's a government facility, we need to know that indeed these doctors are working for more hours, and therefore they need additional officers or medical officers to work.
Now, as we're looking at pooling, or rather building on human capacity, the statistics for Kenya, a ratio to patient to doc ratio, we have 19 doctors serving 100 patients. So when you do the math, is 1 to 5 point something. That is still below what WHO has a standard. So we're already having a problem when it comes to the qualification under this particular profession. What are you doing to build that capacity?
I don't think, Regina, that we have a problem of qualification. We have so many doctors who have now been trained.
Okay.
And we have taken them through the internship program.
Okay.
I think the problem is employment.
Transitioning from interns to now getting into
Yes, because we have so many interns who have been trained, and they are not able to get employment in some of these facilities.
Why? And what are you doing about it?
The issue is, one, we want the county governments to employ them. All right? So you'll find the challenge that has been there within the county government is the wage bill. The wage bill is so high, and they are not able to now employ. So I think as we look at the sector, we have developed, we have the presidential task force on the health human resource workforce. Mm-hmm. So we are waiting for that report to give us an analysis of exactly how are we going to reorganize our healthcare system in terms of service delivery, where we rely so much on the human resource. It plays a key role in healthcare delivery, specifically universal healthcare. So that's where we have a big challenge because of employment,
also,
where the counties have the wage bill says.
Okay. Now, also on another level is that what is government doing, to address the issue of brain drain? Because we're seeing a lot of export of medical professionals at a time when, there's growing demand for these professionals back home. How are you dealing with that?
If from records or statistics, especially those who have done diploma courses, nursing, for example, which is in high demand, we have opened up many, almost when you go to every constituency now, they either have a Kenya Medical Training College. So we are training a lot of Kenyans, but you see the absorption within the local market is a challenge. Now, what do? We need to open up this market, support them in terms of going to go to the international markets. You've seen our president has been signing bilateral labor agreements with other countries where there's shortage of such kind of human resource. Why why should we keep our surplus, yet they can go and work elsewhere?
Is it surplus? It's just that they've not been absorbed. With the demand and the supply there, it's a lack of absorption.
Like, I think on Thursday we'll be graduating about, I think probably 22,000.
Mm-hmm.
So every year we are graduating these students. And
but they're not, the rate of absorption is still...
absorption, and I'm saying our absorption is a problem. So should we wait until they are all absorbed? Again, they require to be continuously be engaged, because it's a profession that you have to practice so that you become a specialist, or you become more efficient in terms of service delivery.
Are you in talks, is the national government, in talks with the devolved units, in a way to improve, the conditions and terms of service of medical practitioners? We are having strikes. If it's not the doctor, it is the nurses. If it's not the nurses, it's the clinical officers. On and off. And the person suffering is Wanjiko.
Actually, currently we are working very closely with the county government. Every program we co-owned, we develop it together, the county government. The role of the national government is basically to support counties in capacity building. That's why we do the training, and then also technically. So we design these programs together. I think we look at how this service is going to be delivered under this universal health care coverage. And we do understand that there are very critical pillars that we need to have. Number one is the human resource for health. That's one of the key pillars of UHC. Number two is commodity. It's very, very important. Number three, which you have now included, is digitization. And then number four is the healthcare finance, which we are now contributing through contribution of 2.75%. So you can see, if we strengthen all these four pillars, we shall deliver universal healthcare coverage. All the four pillars are critical.
Oh, critical. Now, before we have a look at what our viewers have had to say in regard to this particular conversation, we need clarity. Some few months ago, we had a government official, say that if children or other students are not onboarded onto SHA, they will not be readmitted back to school in January. So basically, how does SHA address the health coverage of students, and also clarity on that particular pronunciation?
I think the misconception that is there is that the government officer or the government this has said this. That's where the problem is. The issue is we are advising parents, telling parents to please, if you have registered and you have paid a member, please onboard your dependents, onboard your children who are supposed to benefit from the medical cover that you are entitled to, because it covers plus your dependents. So that's the reason why you're saying we want, at the time of when the schools are opening, we want to have conversations with parents to ask them, have you onboarded your dependents? That is what we mean.
So it's an advice, it's not a directive.
Advice. You remember, we have the Edu Afya.
Yeah.
That Edu Afya program was only for high school. But now we are saying, under SHA, that Edu Afya program now covers every child in school, whether in private, whether in public, as long as you are registered and a paid up member for...
Does it mean more contributions, or because the parent or the guardian is registered under SHA?
The guardian is registered and paid up because it's the guardian who pays their premiums.
Yeah.
And therefore, it is the benefit of the guardian, the parent, that they also ensure that their children have been onboarded as dependents, so that when they are at home and the child is in school, they need not to worry
about that. Okay, let's hear what Kenyans had to say in regards to their experience with SHA so far.
Affordable healthcare to all Kenyans under the universal health coverage was the cornerstone of the Kenya Kwanza manifesto during the 2022 campaigns. With the introduction of the Social Health Authority, is the government doing enough to resolve the teething problem in the new transition? Come as I engage with Kenyans.
huu mwezi tumeshakuwa na changamoto ya mzee kukuwa na shida ya prostate. Nimeona niliwafungulia SHA nikawalipia 6 months advance. Na juzi vile alienda niliona kama bima yake zingine zililipwa.
SHIF upande hii hakuna public participation yoyote imefanywa kuhusu hii SHIF. Tulikuwa tumeletewa tu kighafla.
Wakapeleka jina langu, wakaniambia kwa hiyo SHA inatakana nilipe 750. Sasa mimi nilishindwa nilipe 750 na wengine wanalipa 300.
Lienda wakaangalia wakapata kuna pesa ilibaki kwa NHIF, ndio imemsaidia matibabu ya kukata matiti kwa SHA.
The government have been calling on Kenyans to register for the new Social Health Insurance Fund. Have you registered? Let's try the code and register now. Code is a simple and efficient way to register. The first step, you dial *147# on your mobile phone. Then you proceed to press option 1, which for the Kenyan citizen, or option 2 if you are a foreign resident. Then you will enter your national ID number. Filling all the information, you will receive a confirmation code informing you that your SHA application has been received and is queued for processing.
Unapata system hazifanyi kazi, tena unaambiwa uende nyumbani utegee urudi tena. Unajua sasa ugonjwa haiwezi goja hiyo wakati unaambiwa utegee.
SHA imeweza kunisaidia, kwa hivyo ni mpango mzuri ambapo wanabodaboda wetu tunawaomba muweze kujiandikisha kwenye SHA ili uweze kuepuka na yale emergency.
Ni mzuri, tunashukuru kwa sababu sasa tunajitibu kwa hospitali zote bila shida, lakini ile sisi wananchi kuelimishwa na kujua mengi ndio bado.
That is Wanjiko speaking in regard to SHA, prepared by my colleague Khalid there. PS Kimutai, response to those Kenyans.
Those Kenyans are saying, number one, those who have registered, one, confirm that indeed the father is benefited from SHA treatment. The other one, they were supposed registered and they were supposed to pay their premiums. And they're asking, why am I paying? Because you need to pay your premiums. Like that one was the premium of 750 per month. So you pay your 750 per month, instantly you receive care. Before, NHIF used to take 6 months, but now you're saying it's instant. So pay your premiums and you get service at level 4, level 5, and level 6. Where the hospitals are not providing what they call SHA services, are contracted provide SHA benefits. We are saying that every facility need to sign a contract with SHA so that they are in panel and they're able to provide Kenyans service under the SHA. I am saying this, and we have warned them, that the period that we have given them a grace period.
Till when?
We have given them a grace period because we send them, because this is just a second month.
Yes.
We've given them forms. We've told them, not even now forms. We changed from using the forms. We've told them it is now e-contracting. We send there the contract, they sign and they send back because we have digitized our systems. Now, by January, we expect all healthcare facilities that are registered by KMBDC to have signed the contract, and we shall publish the ones that have registered and the ones that have not registered, and we'll be able to take action because they are giving the government a bad name, bad image that we are not offering SHA care under SHA or universal health care coverage. So these are the areas where you find patients are being told to pay cash because they have not been in panel and they have not signed the contract and they demand cash. Yet a Kenyan who has registered and paid their premiums should be entitled for care under the benefits that are provided for by SHA. So that's an area that we are focusing on now on, and we expect we've trained them. We've done virtual meetings. We've trained them on how to support patients who come and they are not registered. We've told them also to set up the customer care desk within there so that any patient who goes to a facility should be able to, and they are not registered, then they should be able to be assisted to get registration. And once they pay their premiums, they should proceed and be treated. There is no need for a patient to be charged, say, 20,000. Yet, if they have registered and the means testing, for those who are not employed, means testing is done, and maybe they are only entitled to pay 6,000 or 10,000 for them to access this service. And they will access this service throughout the year. So once you go to the hospital, you are charged 20,000. Maybe you want to go again for another.
Do these facilities have an option to decline onboarding?
They have no option. They have no option.
So private sector players, we also have faith-based facilities. All of this, they're all directed or are mandated to get under SHA.
The KBC, which is the regulatory body, have already forwarded their details in, and it's been captured in the system. They are within the health ecosystem. So we issued them with what's called the e-contract forms, which we forwarded to them. So we are telling them, please resubmit your forms. There are those who are hesitant. They were saying, we've not understood. We've taken 6 days. We've talked to them. We've trained them. So I don't think they have any option this time.
So failure to which?
They will be deregistered by the KBC straight away.
So
and once their permit, they don't have the permit, the renewal of permit, then that means they will not be able to offer service. So they have no choice. It is a regulator who says, go here. We have taken the details to SHA. Now you should proceed and enter into contract to provide service under SHA. So we have the regulator.
Okay.
So we tell the regulator, do your work. And that's why in these current laws that we passed, we strengthen the enforcement laws by KBC, which is actually the regulator.
Do these patients, does Kenya have time? Do patients have time to wait until January?
Kenyans need to know, and they're right, that once they're paid, if they go to that facility, they should also demand that it is, go there with your ID and say, I've paid for my premiums and I'm therefore entitled to get care here. If they don't provide that, and as I've said, because we are all in the first 2 months, and we're saying now, if you have not contracted, what's holding you from contracting? So we are going to send the regulator to do their job.
So the patient can have there's redress for the patient.
Yes.
So they need to report it to whom?
The regulator, KBC, Kenya Medical and Doctors Practitioners Dentist Council.
There you have it. We've been having Principal Secretary Medical Services, Harry Kimutai, debunking and unpacking what we have, or rather we are in right now, and that is Taifa Care, that SHA, that is Social Health Authority, is providing oversight and directive on. The question tonight has been, do you think that Kenya's health sector is healthy, and what has been your experience? I'm Regina Manyara. I hand you over to the rest of the team for what has been making headlines in the last 8 hours.